Welcome, everybody. Good morning, good afternoon, good evening, everybody, wherever you are. My name is Anna Forendran. I'm the Executive Manager of ICAN. I want to welcome you at the Africa CDC WHO ICAN webinars. And we are already in webinar series 13, and this is week 3. And this week, the topic is who and what is a IPC practitioner, what is the roles and responsibilities. And then we're going to be having the following speakers. Here's the agenda. Prof. Shadei, who is the ICAN chair and also a microbiologist, and I'll explain a little bit more. And then we're going to have, here's the flyer that all of you received to show you who's going to talk. We're going to have some experience from Zimbabwe as well. Then the next one is the some helpful tips to help you with the bandwidth as well. Please mute your microphone and switch off your video to prevent and preserve your bandwidth. If you do have any questions, please post it in the Q&A box at the bottom of your screen. We won't be able to address raised hands. And also, if it's in the chat, it's not easy for the rest of the team to answer. So please just put it in the Q&A box. And at the end of the session, we will attend, or during the session, we will attend to your questions. Make sure that we do display your name on your screen and the country that you are from. If you click onto your profile, you'll see 3 white dots arrives, and there you can actually rename yourself, or you can add on there that you want to for us to be displayed. There will be a Portuguese and Arabic translation, and if you look at the bottom of your screen, as we've indicated there, this little ball, if you click on that, you will be able to see which language you prefer, and you'll be able to choose that. Just for some French speakers, if there's anybody that is French speaking on this session, there's no French translation, but we will have the French session tomorrow, which will be run by Prof. Azus and Dr. Dixon. So looking forward to see you all then there tomorrow. Then also for education and quality improvement purposes, we record all these training sessions. By participating in this session, you consented that you can be recorded. Sorry, I just want to go back. Sorry. So want to make sure that if you do have any questions, you can actually post it to either Susan or myself or Lizzie at ICAN. Here's all the email addresses, and then Susan will post the new or the updated link to join the community of practice. If some of your questions are not answered, or you still want to ask some questions, please join the community of practice, post your questions there, and all of the panel and everybody involved will look at the community of practice on Telegram, and we will answer your questions then from there. If there's anything else, you can always contact us then directly as well. Then want to make sure that if you want to get a certificate, if you at least attend 4 out of the 6 weeks and you stay on each session for at least 60 minutes, you will get a certificate of attendance that will be posted to you. All the slides at the end of the series, we will post onto the ICAN website. We will also send the link of what has been done to everybody that has registered for these presentations or for the webinars, and you will also receive the presentations as well. Then there's the registration link as well. We use the same registration link for all 6 sessions, and you'll see the different dates that is happening there as well. So if you then follow them, you would be able to see. And then just something else I want to just also mention to you that we do run, are going to run a collaboration conference with SAFI, which is the Engineering Healthcare Engineering Federation, and there is a special link to make sure that we and the engineers and the architects and the environmental people understand exactly where we're coming from and how do we shape the future of healthcare infrastructure with taking IPC in considerations. There's some details for you, or if you need to have anything else, we can let you have them as well. And then just as a final one, just to mention as well that we also run our courses. So if you're interested in any of our 6 months fundamental or the 2-year postgraduate, please connect with Yolanda and look at the due dates for them. So for that is for the housekeeping rules, it's all I want to mention to you. I'm going to now hand over and introduce our first speaker, which is, I think everybody knows her. And I want to just welcome everybody on the panel from WHO, AFRO, from Africa CDC, from just CDC, from all our other partners, also the ECHO team, all our interpreters, all the people that has previously been part of our panel, all our collaborating partners. Thank you for your time spent here with us. And then I'm going to hand over to Prof. Folashad Shadai Ogunsola. She's the ICAN chair. She's also at the College of Medicine, University of Lagos. And I think Prof. Shadai is well known with all of you. I think you've heard and seen her a lot of time. So without further ado, Prof. Shadai, I'm going to hand over to you to take us through what is an IPC practitioner. Thank you.
Thank you very much, Anna. I think this particular topic is very important because on the African continent, we've had quite a lot of confusion on who is an IPC professional because a lot of people have been trained and oftentimes certificate courses, but more like certificate training, 3 days, 5 days, sometimes 2 weeks. And so it was very gratifying when the WHO came out and gave us competences that and the skills and knowledge that we expect from an IPC professional. So I'll just take us quickly through this. There's still so much more to read, and I'm going to suggest that everybody downloads the IPC, the competences for an IPC professional from the website, from the internet. One thing we're quite sure of is that Africa needs its IPC professionals. I did a thing through the internet. A few countries didn't have figures, and we have certainly over 181,622 health facilities in 53 countries in Africa. And we also know that Africa is home to many outbreaks of infectious diseases. The WHO AFRO bulletin of July 4th to 10 showed that we have about 139 outbreaks presently ongoing on the African continent. And for all these outbreaks, it's about transmission. When you hear an outbreak, it's a transmission event. And these are where we will also flourish. But IPC is not just about those epidemics, and that has been part of our problems in Africa. The report of the 58th session of the WHO AFRO Regional Committee in 2008 identified 12 proposed actions for patient safety. And the number 5 was to minimize healthcare associated infections. So clearly, HAIs are part of the top priorities for this continent. And it was very clear that when you look through the 12, you will find that number 3, number 4, number 6, number 7, number 8 would require input from infection control. In addition, promoting partnerships between patients, family members, and providing adequate funding, and strengthening surveillance and capacity for research. You cannot do patient safety without surveillance and capacity and research in infection control. So clearly, whatever we do, the patient safety is enhanced by having a competent IPC professional running a functional IPC program. It's not just anybody, but somebody doing it right. So the HAI is a major part, an infection control, for us to be able to achieve patient safety. Then we looked at the core components that I think came out in 2017, this round. And it looked at 8 important components: an IPC program, and then education and training, component 1 and component 3. And when you look at the component 1, and I have paraphrased a little, or should I say, I took out some things, and it said, you need to appoint at the national level a technical team of trained infection preventionists, including medical and nursing professionals, and that this technical team should have formal IPC training and allocated time according to tasks. They must have the authority to make decisions and to influence field implementation. To do that, you have to be extremely knowledgeable, and you must have the skills. And they must have a protected and dedicated budget. There wasn't a lot of studies and in the field, but from those who have been practicing IPC, they recognize that, and this was a good practice statement. In other words, we hadn't done a lot of research, and so the evidence was, but the consensus of all those who are professionals and who are experts was that you must have this trained team. At the health facility level, the component also went on to say that it is critical for a functioning IPC program to have dedicated, trained professionals in every acute care facility with a minimum ratio of 1 full-time or equivalent preventionist per 250 beds. This was a strong recommendation, though from low quality evidence. But what that means is that it was not a randomized cluster. It was, probably observational studies and so on. So clearly, for an IPC program to be, we need an IPC professional trained running it. Then the third one, which was the IPC education and training, also talked about the 3 categories of human resource that were identified and targeted for IPC training, and that they required different strategies. The IPC specialists, who could be doctors, nurses, and other professionals who are members of the technical teams responsible for the IPC program. They should be trained to achieve an expert level of knowledge covering all areas relevant to IPC, including patient and healthcare worker safety and quality improvement, and that they must maintain high-level expertise so that it is important that IPC specialists undergo regular updates of their competences. So we cannot go to sleep. It has to be a continuum. So who is therefore an IPC professional? WHO went on to, and I like a healthcare professional, medical doctor, nurse, or other health-related professional who has completed a certified postgraduate IPC training course or a nationally or internationally recognized postgraduate course on IPC, or another core discipline that has within it IPC as a core part, not just one lecture, a core part of the curriculum. And that it was not enough to have that, but that you must have had IPC practical and clinical training, because lectures do not make the IPC professional. So an effective IPC professional will positively impact safety and quality of care of patients, healthcare workers, families, and visitors. So what are the roles and responsibilities of IPC professionals? These I have put together in a sort of short form, because over 30 minutes, we cannot tease everything out. But you must, an IPC professional must be able to establish, organize, and coordinate the IPC program in his facility or at national level through developing and implementing policies and procedures that are related to IPC. They must have the capacity and the ability to integrate IPC principles in service delivery. And in healthcare facilities where these exist, they must, some special areas that are high risk where infection transmission occurs, such as ICUs, intensive care units, surgery departments, maternal and neonatal services, dialysis and transplant units that have vulnerable patients. The IPC, it is critical that IPC practices are integrated into these services. They must be able to develop and review policies, SOPs, and other guidance documents. And what we would also say, they must be able to contextualize it to their environment in an based on evidence-based practices. You cannot just creatively do something if it does not follow the evidence. They must have the capacity to conduct in-service training in IPC for all healthcare workers using the principles of adult learning. They must initiate and implement or contribute to surveillance for healthcare-associated infections and multi-drug resistant organisms, that's AMR. They must have the capacity to audit IPC procedures, quality of care and healthcare worker infections, initiate and implement or contribute to outbreak management, both within the facility and nationally. They must have the knowledge, the skills, and the competence to provide clinical advisory service on IPC-related matters. In addition, they must have advocacy skills. We all know that in many facilities, many countries, there is no IPC program. Two, it's usually at the bottom of the priorities of management, because even though IPC is cross-cutting and is good practice and will protect, its effect is not always an immediate thing. And so if in many struggling healthcare facilities and countries, it's been difficult for them to match the importance of IPC to immediate and urgent needs. So IPC tends to be in the box that says it is good, but not urgent. Whereas a lot of other things are in urgent and good. But soon, if you leave it, it becomes urgent. One major part of the job of IPC practitioners and professionals is to ensure compliance with regulations and the requirements of accreditation bodies, not just of the organization, but of individual healthcare workers. They must be collaborative, so they provide linkages with the laboratory, with WASH, with nursing department, with clinicians, with the microbiology laboratory, sterile services, pharmacy. In other words, they must be able to work with all those stakeholders that will make sure that infection prevention occurs. They must perform annual risk, they must have the capacity and the ability to perform annual risk assessments and develop action plans from the previous year's activities. So you provide an action plan for what you will do for IPC this year, you follow it through, and then you carry it over and provide the next one, because that forms a framework for the work you will do every year. They should also have the capacity, the competence to make recommendations for the built environment. We know that the built environment can affect transmission. So they should be able to have an input right from the beginning up to when the building is commissioned, and to make sure that whatever is being done conforms with national or global standards and certainly best practice. They will work with a team to ensure the health facility is always in a state of preparedness for outbreaks and epidemics. Africa, as we heard at the beginning, there are lots of outbreaks. We're just coming out of the COVID outbreak. And hospitals need to prepare ahead of time. Preparedness is something we do proactively. We do not wait till the epidemic is on us before we start to infection-proof our hospitals and healthcare facilities. They must have linkages with the ministries of health, the states and local governments or district officials on anything IPC related, because the organisms do not know boundaries. So infection prevention is a continuum that goes from healthcare facilities into the community, from the community back into the healthcare facilities. So there are stakeholders everywhere. And so you cannot work alone. So what are the types of skills required by an IPC practitioner? First of all, let me define what skills are. An ability and capacity acquired through deliberate, systematic, and sustained effort to smoothly and adaptively carry out complex activities or job functions. And there are three types of skills. Skills around ideas, what we call cognitive skills, which would allow you to, makes you learn, your ability to learn, ability to be creative, ability, your curiosity in your environment to connect dots. Those are cognitive. Then things, technical skills, the doing, not only in terms of IT, but also things on the ground, what you do, how you implement your IPC. And then people. IPC is all about people. The IPC practitioner cannot make a hospital safe. It is about changing behavior of healthcare workers, everybody involved in the administration, such that everybody now sees IPC as an important component of a good, strong healthcare system. And so people are very central to the function of an IPC practitioner. So IPC practitioners without people skills will not be successful. So an IPC professional needs to have these three types of skills. And it becomes particularly important in Africa, where in many places there are no programs, where there are shortages. So the creativity and the knowledge base of knowing what works, what doesn't work, and how you can adapt to the environment to make sure that you get the things done, even when they have meager resources, becomes an extremely critical skill to have. Then you have all the on-the-job skills. IPC requires walking up and down, doing surveillance, visiting, checking. So you've got to be energetic, you've got to be active. And because you're going to be getting lots of information from different places, you have to be organized. And in organizing, you have to find the best way to organize. And IT, using the IT systems is a great way. So you've got to have that. You have to be able to plan and conduct training. You have to have excellent writing skills. You have to have good oral communication skills. As I said, people are central to what we do in IPC. You must be able to manage your time because you have many things to do. So you must be able to ensure that you have time and you know when not to take on things. Being creative is fundamental, and good presentation skills. These are not everything. And you will find that, you're being collaborative and so on, which I had said earlier are part of this. So what is the minimum educational qualification required for an IPC professional? In general, the IPC professional, if they're in secondary and tertiary levels, tend to work in teams. And the team is usually made up of an IPC doctor and one or more IPC nurses. But in some countries, the IPC professional can be a nurse and they work alone, even in these, nursing teams. But whether doctor, whether nurse, whether they all must have the skills and characteristics. So they tend to have a background in nursing, in medicine, clinical laboratory science, medical laboratory technology, microbiology, epidemiology, public health, or related fields. Those who are not medical or nursing usually will not have a lot of in acute care hospital settings within the wards. That requires that you have those clinical skills, but the IPC is so cross-cutting that there's a role for everybody. So, and during epidemics when everyone is out on the streets, those differences become more blurred. Non-clinical IPC professionals may be more involved in non-clinical areas in acute care hospitals, or they will be more involved in the community, especially during outbreak response. So the ultimate goal of an IPC professional is to establish and or support an organizational structure to effectively prevent HAIs, reduce AMR, and improve the safety of patients, healthcare workers, and visitors in order to achieve healthcare without avoidable infections. This is by WHO. So it is essential to achieve in any healthcare facility the full requirements of the core components, but recognizing that achieving those full requirements may be resource intensive and that you cannot wait till you can do it. You start wherever you are. And WHO has helped to identify the minimum requirements we require for us to have a level of safety. And these have been divided based on the levels of care. And these are the minimum requirements. So in doing that, the core competence of IPC professionals were identified, and the minimum requirements for the IPC professional at these levels of care were also discussed. So when WHO came out with these core competences, I felt it was important for us to talk about what are core competences, what do we mean by core competences. And they are the knowledge, the skills, and attitudes. So it's beyond just knowing, it's beyond having the practical skills to do, but it also involves your disposition to doing, your attitude to the work, which go to some of the attributes that would help you to continue to function. And in our countries where systems don't occur, IPC professionals often need to be in fact, not often, require the passion to be self-motivating because it can be daunting. So they're required for an IPC professional to practice with an in-depth understanding of situations, using reasoning, critical skills, thinking skills, reflection and analysis to inform assessment and decision-making in the prevention and control of HAIs and AMR. So what do these competencies mean? So for you to have the competence, you have to have knowledge, you need to have skills, your behavior and attitude matters. And then clearly you need to have been practicing. The more you practice, the better the competence. So it means the more you practice, then you use the knowledge, the skills, and the behaviors and attitudes so that your competence improves with that. So the competence, therefore, is a set of individual performance behaviors which are observable, measurable, and critical to successful performance. So skills plus knowledge plus abilities equals competence, and the ability comes from your behavior, your attitude, and your practice. So IPC practitioners must have the competence to perform their job across different care levels. So what are these minimum requirements of IPC professionals in implementing IPC? At the national level, 1 full-time focal point trained in IPC is required as a minimum, with a dedicated budget for implementation. Trained, 1 minimum. And the responsibility to make this happen is with governments. They must employ this person, ministers of health and finance, to ensure they have a budget, or the people who would actually sit to do that might be the National IPC Committee or Technical Working Group, if they exist, or can come from other program leads that exist or technical partners that are in country. At the different levels, the IPC professionals required to implement are a minimum of an IPC trained link person and healthcare officer who is part-time. In other words, the IPC link person may not have all the competences, but must also have at the next administrative level, somebody who can oversee what the person does. Because at primary care, and there are many types, the level of activity is reduced. There are less invasive procedures, and so on. And patients who are really ill are referred to higher levels. At the secondary care and tertiary, you should have a functional IPC program with the team, and you must have trained IPC focal points, nurse or doctor at 1 to 250 beds. So depending on the size of these, they should be full-time and they must have dedicated budgets. And at the tertiary level, you should have multidisciplinary committees and team as a minimum. This is not to say that you cannot have a multidisciplinary committee and team at the secondary level if you have the capacity, because we're all going towards the best. So the minimum requirement is not where you stop, it's where you start. And then at the tertiary, access to microbiology laboratory. But the others can have access to microbiology laboratories in an indirect way. So there might be a reference laboratory in the country where things can be sent. So the competencies for an IPC person can be divided into 5 areas and 16 domains. These are things you need to know and things you need to have skills to perform. So the first area is about leadership and IPC program management. And you have 2 domains here: how to establish your program, how to get it running, how to collaborate, work with other people, teamwork, and so on. And then the built environment, which we had mentioned earlier. And then the second area, microbiology and surveillance, you must understand the organisms. The foundation of IPC is on HAIs, and HAIs are about microorganisms. And you have to understand what they do, where they are, how they transmit, because everything that we do is based on understanding the behavior of the microorganisms. And we also need to understand what healthcare associated infections there are and how we respond to these infections so that we can intervene properly. Then there's IPC in clinical practice that speaks to the standard precautions, the transmission-based precautions, and the competencies you must have about decontamination and reprocessing of medical devices and equipment, how to deal with catheter-associated bloodstream infection prevention, catheter-associated urinary tract infection prevention, surgical site infections, healthcare-associated pneumonia, healthcare-associated outbreak prevention and management. So all these are the IPC in clinical areas. And in doing these, you also need to understand how the built environment affects them. So there's a lot that goes into all these, and these you will find in the book, in the guidelines that came out on the IPC competencies. Then education, fundamental to what the IPC practitioner does, apart from implementing the program, which is critical, because if you're training people and there's no framework of a program for them to work in, the training soon goes down the drain. Is about education. And because this education is about training healthcare practitioners to be safe, to perform their duties in a safe way, and for them to also contribute to the overall safety climate. You have to have good presentation skills, you must have good adult learning, understand how adults learn, and so on. So these are competencies that you must know. You have good communication skills as well. And then any intervention, you have to look at what went wrong and improve on this. And so quality improvement is another critical area, and patient safety and occupational health. One of the things that we know, the viral hemorrhagic fevers, COVID, and so on. Healthcare worker deaths were unacceptably high. So the healthcare worker who works in this environment where infections are being transmitted has to be protected. There can be no patient safety if the healthcare worker who's to do this cannot. So the competence in this area about quality, patient safety, and occupational health is looking at improving the care and the quality of care and the safety of care, and also about the healthcare workers who provide this care. So I just gave a little breakdown of one or two areas. So if you look at area 1, leadership and IPC program management, the first domain that says IPC program management and leadership, please ignore the built environment on, says you use management strategies and leadership skills to operationalize IPC teams, develop or adapt and implement evidence-based IPC guidelines, SOPs, training resources, and monitoring and audit tools. You use your skills to train and educate healthcare workers, carry out monitoring and feedback activities, use data and evidence for decision-making, which means an IPC professional continues to learn, must continue to read. New guidelines are coming out every day. New evidence is coming out to tell us what works and what does not. Support WASH activities, because no healthcare can be done without water, sanitation, and hygiene. You cannot prevent transmission easily in those conditions. And to be conversant with the supplies you use, how they're procured, and how much is used, so that you can prepare not just for the normal days, but also to prepare for surge capacity, to have the surge capacities. So you also have the domain 2, which is the built environment. And it talks about how you can use this to improve the healthcare environment, using a risk-based approach for providing the appropriate infrastructure and services, to do infection risks related to building design, to assess needs for IPC and WASH equipment, environmental cleaning and waste management, to monitor WASH indicators and support WASH training activities. And there are more. All these can still be teased into smaller activities. And then you look at microbiology. You must be able to identify the microorganisms, especially in the healthcare setting and the context of the global, national, and local epidemiology. So you must know the epidemiology, understand their modes of transmission, understand antimicrobial resistance patterns. And AMR prevention, understand resistance mechanisms, understand basic concepts of surveillance of AMR, contribute to develop or to improve and sustain AMR surveillance protocols, including alert and detection systems, as well as evidence-based infection prevention and control strategies and policies for AMR at the national and or the facility level. You must be able to implement AMR prevention activities at the national and or healthcare facility level, and conduct or support training activities on AMR detection in healthcare. So all these are just examples of how these domains are broken down. And it goes on till you've dealt with the 16 domains for IPC. And each under these ones, there are a number of activities that need to be done, which are more broken down. So what are those specific? So for you to have those competencies, we talked about having knowledge to achieve the competencies. And the knowledge that is required for each domain, which I'll just take you back: leadership, microbiology, IPC in clinical practice, education, and then quality, patient safety, and occupational health. Also further arranged around things like basic principles that guide that subject matter, policies and guidance that you need to know so that guide the implementation, leadership and implementation, talking about the roles and responsibilities of organizations and healthcare workers, communication and advocacy to aid behavior change, facilitate implementation and stakeholder buy-in. Now, not every domain has every single one of these, but all these most of them will have either understand the basic principles, you must understand the policies, most of them will have policies and guidance that an IPC person must understand these. So the knowledge, the critical part of this, that knowledge must be evidence-based. So you must get the knowledge from papers, from guidelines, from WHO, CDC, Africa CDC, which have been well researched, so that you do not act by your opinion, but that you go for where the guidances are, and you continuously check to find whether there are updates and follow these for your work to be properly done. So the specific abilities to achieve these competencies must be, the IPC professional must be able to demonstrate them around policy and guidance, how you develop policies and guidance documents for leadership and implementation, to identify gaps, use risk assessments to plan, to collaborate with others, and use multimodal strategies to ensure behavior change. And then around education and training, communication and advocacy, monitoring and evaluation. These are all abilities that must be. And so what are the essential core behaviors that we want from an IPC person? He has to be passionate, because sometimes that is all you're going to have, especially in the continent where there might be no reason for his or her own actions. He must be very approachable, communicative, thorough, diligent, and very perceptive. In other words, emotional intelligence has to be high. An IPC professional is a role model, or should aspire to be a role model, and will advocate for IPC. It's a good leader and team player, encouraging individuals and teams to learn and develop IPC best practices. He's a good communicator, appropriately communicating about risks and recommended IPC practices while explaining the evidence basis. It is absolutely critical that the evidence basis is explained. And is a competent auditor, supporting individuals and teams with audit, surveillance, and feedback. So, but there are challenges to training of IPC professionals. In many of the countries on the continent, there's no career path for IPC professionals. So those that have been trained often go back to their facilities and after a while drift away, because they move into other parts of their work because there's nothing for them to do. There are very few functional IPC programs. So when people are trained and go back, nothing to do. And people do not come into IPC because there's no progression. So they go in and then they're transferred to other units. And so it's been almost like a waste of the investments, but things are beginning to come together. And so as we push forward with the core competencies, with the fact that we're now talking about having trained IPC practitioners, then we're going to start to, and there's a lot of advocacy for career path. We hope that in the next few years, we will start to see people being employed specifically for IPC, because the programs cannot develop till somebody has dedicated time and is paid to ensure that it happens. We already are seeing courses in some countries and associations. So, and ICAN has been running courses for over a decade. And Anna showed that at the beginning of the course. The challenge still is we need the programs for these professionals to work within, and we need for them to be valued so that they can stay in that profession. We've had loads of training on the continent, but not for professionals. So in summary, the need for trained IPC professionals is becoming incontrovertible. The core competence for IPC professionals by WHO has given us a framework for the development of this cadre of staff. The amount of evidence that now exists in IPC requires in-depth knowledge and skills to be effective in creating a safe environment of care. The IPC professional is multidimensional, requiring competencies in leadership and IPC program management, microbiology and surveillance, IPC in clinical practice, education, quality, patient safety, and occupational health, which are the 16 domains. So, but with all this said, the ultimate role of the IPC professional is to prevent infection where healthcare is practiced. Thank you very much.
Thank you very much, Prof. Shaddai. This is very insightful, and I think everybody really appreciate this. And I think we can speak for days and on end about this. So thank you very much. We're quickly going to have a short video just to allow the interpreters to rest their voices. So if Prof stops sharing, then we will share the video. It's just about healthcare workers, a very short one, and then I'll introduce the next speaker. Thank you. Prof, just stop sharing your screen.
Oh, sorry.
Okay, so Alina, you can just play the video for us, please. Thank you.
Sure, Anna, just a second. I hope I've been able to.
You can see your screen, just put it in slide
Next
mode.
tonight, the CDC this evening and their concern over a deadly superbug.
So how does nightmare bacteria sound?
That by 2050, superbugs could kill 10 million people a year.
You could be carrying it into a loved one's hospital room and not even know it. So hand washing and avoiding skin-to-skin contact is key.
75,000 patients die each year from healthcare-associated infections, yet most of these infections are preventable. Leading the charge to prevent healthcare-associated infections are infection preventionists. IPs lead infection prevention and quality improvement efforts across the healthcare continuum.
Infection preventionists are the central nervous system and the backbone of infection prevention in every setting. We can't prevent infections without infection preventionists.
Every day, IPs look for patterns of infection within facilities. They identify and investigate resistant organisms and outbreaks, collaborating with facility leadership and public health agencies to find the source of dangerous pathogens. More importantly, they strive to make sure patients don't get infections from healthcare treatment to begin with. They observe healthcare processes, research evidence-based practices, and develop policies to protect patients and healthcare workers. They educate healthcare teams and collaborate with multiple disciplines to implement these practices within clinical workflows. The IP's influence extends to every area of the hospital. And their work pays off. Since 2010, infection preventionists' diligence has contributed to tens of thousands of lives saved, millions of fewer patients harmed, and billions in cost savings.
My name is Bria Graham Glover, and I've been an infection preventionist for 6 years.
My name is Grace Nkonge, and I've been an IP for 6 years today.
My name is Mala Philippel. I've been in infection prevention for 33 years.
I'm Uzumaka Obiekwe, and I've been an infection preventionist for about 3 months.
My name is Michael Ampries, and I've been an infection preventionist for 10 years. I love my job. It is different every day. You have the opportunity to interact with all disciplines and people from all walks of life and patients as well as staff. And your focus is on quality improvement and really making a difference.
What I love most about being an infection preventionist is the unexpected. I love coming to work every day and knowing that my job is going to take me on a new journey.
I love that it's an all-encompassing field. I had no idea that I would be doing everything from construction to infant formula preparation. Everything in this hospital has infection control implications.
To be in. It's a fascinating, ever-evolving, ever-advancing career that I think is becoming more and more prominent and more important in this healthcare quality reimbursement scenario that we're living in.
If you want to save lives, join us.
Thank you very much, Alina. And this was just something to just give us a little bit of an idea why we are here. I want to introduce the next speaker, Dr. Atmaya Simbarashi. I'm not going to even try and pronounce his last bit of his surname. Dr. Atmaya, you can pronounce it for us. Thank you very much. He's a MSc Tropical Medicine and Internal Health. He's done his DTMH at UK, diploma in IPC in Zimbabwe, diploma in TB in Japan. He's currently the Provincial Epidemiologist and Disease Control Officer, Ministry of Health and Childcare at Mashonaland Center Province in Zimbabwe. Over to you, Dr. Atmaya.
Oh, thank you, Anna, and good morning, good afternoon, good evening, everyone. It is quite a great honor for me to be speaking at this webinar on a panel with quite great minds in IPC from across the globe and from across Africa in particular. I'm also excited to be sharing my story in IPC as a medical doctor who has been in this journey for about 8 or so years. Yes, my surname is Muronga Zombo. I know it might be difficult for many people to pronounce, but it's okay. You can call me Dr. Atmaya. That's completely fine. So I'll move on to my talk for this afternoon. I would just want to cross-check if you can see my screen and if you can hear me clearly.
Yes, we can, and we can see your screen. Thank you.
Thank you so much. So I'll be talking about my IPC experiences, and my IPC experiences are around IPC implementation, research, as well as IPC teaching in the academia. So this is what my presentation is going to be like. So I will start from the basics. So my journey relationship at the Central Hospital, and my desire was to just be involved in preventive medicine. I had this notion that prevention is better than cure. So I wanted to get into public health, and moving to a district hospital would afford me this opportunity to, practice preventive medicine and offer me a career path in public health. So I moved to work at a district hospital where there was a high burden of HIV, TB, and malaria. I know in sub-Saharan Africa, we are a high burden area, but this district. So my passion really in IPC developed after a visit, a site support visit by what we used to call IPC people at that time. Before I became an IPC person myself, this is the tag that was given to people who are involved in IPC. So many people used to feel that they're quite detached from IPC professionals. So that's why they labeled them as just the IPC people. Thereafter, after showing my interest, I was nominated to attend the Trainer of Trainers training. It was a national training. And I was one of the first 2 medical doctors, to be involved in that kind of a training. And thereafter, I was appointed by the provincial medical director to be the provincial IPC focal person. This was a supplementary role to my role at the district hospital, where I was just basically providing clinical input. I was practicing as well as also supervising facilities in the district. And also after this appointment, I pioneered with a team of 5 nationally trained IPC professionals. We pioneered a Ministry of Health-led IPC program in our province. Previously, the IPC program was being implemented by a partner under the Zimbabwe Infection Prevention and Control Project, ZIPCOP, which was funded by CDC through BRTI. But when this was, it was seen that it would be good to have the Minister of Health taking a lead. And I was one of the first few people to get into that. I then got membership with our local body, ICAS, and also ICAN. And then later on, I enrolled for a postgraduate diploma in IPC. And then this was again in a pioneering class. Prof. Sade mentioned that some countries have indeed started postgraduate courses, and Zimbabwe is one of them. So this basically is an introduction to my IPC journey, which I've been working ever since. So I will talk about my interests, which are basically around antimicrobial resistance, occupational health, TB infection control, outbreak control, and surgical site infection. I mention these interests because they are going to be important when I talk about my research areas. So I will move on to talk about the training which I have received in IPC. Prof has highlighted some of the competencies that are required in the training that someone requires for them to be an IPC professional. So I've received quite a wide range of trainings, some professional, some academic, starting with a course in TB in Japan. I mention it here as IPC related because there was such a strong focus on TB infection control. And thereafter, I also did the postgraduate diploma in IPC. I attended the advanced IPC training in Geneva, funded by the World Health Organization. And like highlighted by Anna, I've also pursued a master's in tropical medicine and international health, in which is inculcated the diploma in tropical medicine and hygiene. And the focus for my options, I chose the modules which were related to IPC as well as research. And that would include also WASH, a module on WASH, as well as a module on antimicrobial chemotherapy. I will move on to talk about my IPC implementation experience. So I will start with the district experience where I was working at the district hospital. At that hospital, I was working as a government medical officer, and later on I became the district medical officer in charge of all the health services in the district. And I sort of classified my experiences according to the WHO core components in relation to what exactly we were doing in that district. So firstly, in terms of the IPC program, we managed to establish a district hospital IPC program where there was an appointed a trained IPC focal person, and there was a setting up of a multidisciplinary IPC committee, which I actually chaired. And through that committee, we adapted and adopted nationally provided standard operating procedures, guidelines, policy documents to meet our specific needs. And then we also had IPC training. Having received the trainer of trainer training, I facilitated 3-day basic IPC training for all the IPC committee members, and also conducted regular on-job training. And of particular note is that I also became a role model. Prof mentioned that an IPC professional should be a role model or should strive to be a role model. And this is what I also did. I will mention in particular hand hygiene. I became an advocate for hand hygiene. And you can see on the picture on the right, where I actually was moving around with a bottle of alcohol-based hand rub fastened somewhere to my belt. So that because I was moving around the hospital, I really needed to have something that I could use to perform hand hygiene everywhere where I was. In terms of surveillance, we looked at two.
Dr. Meyer, I'm sorry to interrupt. Can you please go a little slow? The interpreters are asking to go a little slow. You're very fast.
Okay, thank you. Thank you for that.
Sorry for interrupting.
Okay, that's fine. So in terms of surveillance, we introduced, working with our team, the IPC committee, we introduced surgical site infection surveillance with the checklist that we were using. And also we inculcated TB screening amongst healthcare workers through the wellness clinic. So the wellness clinic would check for other things like hypertension, diabetes, as well as specific other things like maybe cervical cancer or prostate cancer for men above the age of 50, but also targeting TB amongst healthcare workers. And these practices were monitored and audited through a nationally run audit process where site support visits were conducted at our facility by IPC professionals. I will show in the next slide a presentation which I made at the ICAN Congress in 2018, which summarized and looked at the impact of these site support visits on our district hospital, where it actually showed that since 2013, when we had the first visit, which unfortunately was not graded, so we don't have the percentage score, which was awarded to our facility after administering a checklist, which looked at the various domains in IPC. You can see that from 2013 up to 2016, these 6 visits resulted in a steady increase in the performance of the hospital with regards to these scores, from a poor grade or class to a class where we were actually regarded as a very good performance, that is S1. So this was the team, which was multidisciplinary committee, which was doing this work, working very hard to achieve these successes in the implementation of IPC at this hospital. So I will move on to talk about my provincial experience. So my initial experience at the provincial level was when I was appointed to be the provincial IPC focal person. So this was before COVID-19. So I worked as a government medical officer, but also at the same time being the focal person for IPC. But later on, after COVID-19 came, I was appointed to work in a full-time role as the COVID-19 coordinator. So I will talk about my provincial experience first. Like I highlighted, this was really a Ministry of Health run IPC subnational program, and I led a team to conduct site support visits at various sites in our province, which included rural hospitals, general hospitals, mission hospitals, district hospital, and the only provincial hospital that we have. And this resulted in marked improvement in IPC practices. We actually particularly realized successes in the low-cost interventions, such as the administrative TB infection controls and also IPC surveillance. This exercise really, and this project, which we carried out, demonstrated the value of using the site support visits with a color-coded checklist to improve IPC programs. So this work, again, I documented it with the assistance of my colleagues, and came up with an abstract which I presented at the International Conference on Prevention and Infection Control in Geneva in 2017. And it was actually published in the ARIC journal, Antimicrobial Resistance and Infection Control journal. So I will move on to talk about COVID-19. So as I highlighted before, when I went to do my master's in the UK at the London School of Hygiene and Tropical Medicine, I focused on the healthcare associated infections. And when the COVID-19 outbreak started, I was still in the UK, and I thought about orienting my thinking around COVID-19, and I conceived a research idea on COVID-19. And at that time, they were not we didn't have any serology test, lateral flow assays or rapid tests in serology, but my idea was around that. And I wanted to look at the risk that is associated with getting COVID-19 infection amongst healthcare workers. So working with my supervisor, I managed to conduct this research, which I will talk about later. And this thinking and this inclination towards COVID-19 sort of equipped me with COVID-19 skills. And then when I came back to Zimbabwe, I was appointed as the provincial COVID-19 coordinator and was basically doing clinical management initially at a 10-bedded provincial center. But then later on, I went on to, after decentralizing COVID-19 care, as I will highlight later, I moved on to more supervising the clinical care at the admitting facilities. And also public health role in coordinating the 8 district rapid response teams in the COVID-19 outbreak control. So this, the COVID-19 outbreak really opened, a whole new experience in IPC, because IPC before that was sort of, not really looked upon to be or highly regarded. But COVID-19 really demanded that everyone should know about IPC, and in that regard, a provincial IPC focal person was also assigned, and I worked with this IPC focal person in capacitating healthcare workers in IPC. So this IPC focal person was a dedicated cadre in this, while I was doing COVID-19 coordination, but the IPC focal person was more focused on the IPC. But I will say that my IPC knowledge was quite key in this. And I will talk about how we managed the 4 waves that we had in Zimbabwe, where we had to think about a strategy for each wave, and how we had to work with districts and facilities and conduct IPC risk assessment, and how we had to also conduct risk assessment in schools, because at some point for schools to be opened, it had to be seen whether the schools were meeting the requirements for them to open. And also my provincial experience saw me seeing the launch of the COVID-19 vaccination program, which had many ups and downs, and also cross-border collaboration issues with neighboring countries. So I will talk a little bit more about our experience with regards to the wave-specific case management that we implemented in our province. So this this graph is showing us the 4 waves that we had in our province. And for the first wave, you can see that this was really being managed at the tertiary level. There was one center which was managing COVID-19 in our province. Otherwise, the severe cases would be referred to the central hospital outside the province. And then for the second wave, which was now a bit stronger, we also still were managing the cases at a tertiary level, where we had a provincial center and then opened 2 more hospitals to manage that. But before the third wave, that was the Delta, mainly driven by the Delta variant, we came up with a strategy to decentralize care to hospitals, to all the hospitals in our province, and capacitated staff on IPC and case management for them to be competent enough to manage moderate and severe cases. And then for the 4th wave, which was now driven mostly by the Omicron variant, we realized that the numbers would be very, very, very asymptomatic, and mild cases could be done at primary level. So someone who is coming for something else, which is not COVID. Maybe they want to deliver. We wanted our staff to be competent to manage the cases at the primary level. Because previously, all COVID-19 cases, regardless of their actual needs, even if they've got maybe they've been involved in a road traffic accident and they happen to be COVID-19, they would be referred to a COVID-19 specific facility. So this really involved a lot of training, a lot of case management capacitation, and it really, in the end, averted unnecessary movement of patients and prepared our province for any future waves. So this work was presented by my colleague at the ICAN Congress in 2021. So here I just try to put some pictures to summarize my experience in what I'm currently doing, which involves IPC in schools where we went to assess schools and capacitate them on IPC before opening of schools. Also responding to IPC outbreaks in schools. For example, this was a boarding school where there was an outbreak and we had to set up a makeshift clinic. So this kiosk was actually not a kiosk, but a temporary clinic to cater for the learners. And also training of support staff who include nurse aid, general hands, as well as village health workers. And here I was on national TV advocating for the COVID-19 vaccine. And here I was investigating an outbreak, a diarrheal outbreak. And lastly, here I was involved in a cross-border collaboration meeting. So I will move on to talk about my national experiences. At the national level, I am a member of the National COVID-19 IPC pillar. I'm also a member of the Infection Control Association of Zimbabwe Research Subcommittee. And I've been involved in 3- and 5-day healthcare worker training as a trainer, and then also I was part of the National IPC Program Implementation Review, which was done countrywide in 2019 using the WHO IPC Assessment Framework. And then I was also involved in the development of the IPC short modules, which are being used in Zimbabwe, and I developed the occupational health module. And recently I've been involved in the writing of the National IPC Policy Strategic Plan and Monitoring and Evaluation Plan, which is currently being reviewed. So I will move on to talk about my research work. Like I highlighted before, my interests are coming up again, where I will talk about the research work which I've done in tuberculosis infection control, surgical site infection, and occupational health. So I will start with the TB infection control. We all know that one of the is part of the hierarchy of TB infection controls. We have got the managerial, the administrative, the environmental, and the environmental controls, and the personal protective equipment. And the administrative controls, they set out that we need to, the moment a patient or a suspected TB or presumptive TB patient gets into contact with the health delivery system, we need to make sure that we quickly identify that they're coughing, we fast check them, ensure that they are screened, ensure that we have put a high index of suspicion, we've taken a sputum sample and sent it to the lab with a quick turnaround time, and ensure that we quickly initiate patients on TB treatment, so that the risk of transmission of TB, whether in the community or in the healthcare setting, is reduced. So with my colleagues, we did a step-by-step analysis of the cascade between presumption of TB to treatment, to really check where exactly if there were any delays in the process and where these delays were, and also trying to find out the factors which are associated with these delays so that this could be addressed. Our study really here, this is the summary. It noted that of the people who were suspected to have TB, about 20% of them were lost to follow-up. So no one knows where they went. And they eventually didn't get a diagnosis of whether they actually had TB or not. And factors which are associated with this loss to follow-up included having been registered at a rural health center or at a facility which is more than 2 kilometers from the lab, and the absence of an environmental health technician. So as a result of these findings, you can see the cascade from presumption of TB until treatment. You can see that from presumption of TB, sputum is collected, sent to the lab, received at the lab, examined, and the results are made available so that the diagnosis can be made and the patient can be treated. And in this cascade, you can see that the largest drop or largest degree of loss to follow-up was between the sputum being sent to the lab and the sputum being received at the laboratory. So there were challenges with specimen transportation from the 19 facilities, 19 rural health centers in the district to the district lab, where the sputum was supposed to be investigated. So as a result of these findings, there was a change in policy in practice where the district health executive took ownership and provided fuel to ensure that every week and sometimes more than twice a week, specimens were taken from the facilities. And later on, I think within a year, there was a partner who then supported a specimen transportation, a cadre with a motorbike. And this, cut down the possibility of such loss to follow-up. And then lastly, we had at that time, some facilities didn't have an environmental health technician, but then there was lobbying of opening of posts for environmental health technicians, which has resulted in an EHT at every facility. I will also talk about my surgical site infection study, which I did in the context of my postgraduate diploma in infection control dissertation, where I looked at the rate of post-cesarean surgical site infections, as well as...
Sorry.
Yes, hello?
We need to wrap up so that we can have time for questions and answers, please.
Okay, that's fine. So here, this study showed that the degree of surgical site infection was actually low, but there was a lot of significant social and economic impact that we noted from this study. This is the healthcare associated. Hello. Okay, so I touched a little bit about this study, which provided early insights into the prevention and control of healthcare associated SARS-CoV-2 infection, and which showed a high SARS-CoV-2 seropositivity after the first wave at 2 hospitals in London, and a dose response association was noted, where if the exposure grade was with the increase in exposure grade, there was also an increase in seropositivity. This again, you can find this on my reference list. And I'm also involved in IPC, trained part-time lecturing at the Bindra University of Science Education. So I lecture on all the modules of the diploma in IPC course. And in conclusion, I've had a unique experience working as a medical practitioner in IPC in Zimbabwe and any other emerging disease outbreak. And my expectation is that we need to document our IPC activities and write them up and ensure that we publish them so that we contribute to the body of scientific knowledge and also that we influence change of policy and practice. So in conclusion, I would want to encourage us as IPC professionals that we need to, as inspired by the multimodal strategies, we need to build it, to teach it, to check it, to sell it, and to live it. Thank you. This is the end of my presentation.
Thank you very much, Dr. Atmaya. It was really very insightful, and thank you very much for sharing with us. I'm going to hand over to Dr. Yewande Alimi from Africa CDC, and she's going to facilitate the questions and answers. Over to you, Dr. Yewande.
Thank you very much and good afternoon, colleagues. We have a few questions already on the chat box, and we encourage participants to include questions that you'd like the expert to answer. I'd like to thank Prof. Shade Ogunshola as well as Dr. Admira from Zimbabwe for the very insightful presentations. Professor Ogunshola, the first question is to you. It's around understanding the emulative health promotion in Canada. The question is, that is a critical perspective on practice. Can we only depend on this ideation because it includes systemic methods of education, community and individual efforts in favor of IPC? Prof, if you'd like to take that question, and please to the interpreter from ECHO, please mute yourself. Thank you. Over to you, Professor Ogunshola.
Yes, thank you very much. I have to confess that I'm not sure I know what you mean by emulative, health promotion. If it's, well, let me tell you what I hope I'm getting. It's a way of a very comprehensive health, taking the community and so on into consideration, but I'm not sure that it is around IPC because I think it's more of a population health method. That's about all I know about it. So if it's related to IPC, I don't know about
that. Thank you very much. I have other experts as well on the call. So if you'd like to chip in, I'm keeping an eye on both the Q&A as well as the chat function. The next question is to you as well, because you had indicated you wanted to give an answer to this. Prof, please, can you throw more light on the differences between skills, practice, and competence in the context of infection prevention and control?
Thank you very much. Let me say that skills is like a unit of a measure of work. It's measurable. It's the ability to do something. So the ability for you to do hand hygiene, the techniques, the steps for hand hygiene. That's a skill that you've learned. Competence goes a little bit further. It's the skill plus the attitude and the wanting to do it. So it's the hand hygiene and doing it at the point of care to achieve something and continuously doing it, having there's a bit of behavior in this, and it also has within it, when you say competence, an expectation of something that's going to happen. So, and an expectation from you for compliance. So it's the skill, you know how to wash your hands, but taking the step to do it at the right time, that's the competence. Now, the practice is when you do it regularly. The frequency of doing is the practice, so that it becomes the habit. So you have the right attitude because you're struggling to ensure you're doing it at the right time, but you have the skills. The skill is the actual how you wash your hands. The competence then takes into consideration your motivation, your wanting to do it as you have been taught at the right time, every time you are at the point of care, then it becomes more of a competence. So a skill is a part of competence, but the competence is beyond the skill. And sometimes, the competence is not necessarily as easily measured because you measure the skill and then there's also a value of behavior added onto it. So I hope that helps.
Thank you very much, Prof. Ogunshola. Dr. Admira, I'm going to throw this next question at you, but otherwise, if any of the other panelists from our representative organization is interested in answering, please just raise the hand and I will come to you. This question is around, I think the participant is interested in setting up a tool, a surveillance tool, focused on central line associated blood infections. The person would like to do this surveillance in about 2 of their hospitals. So if you have any comments, insights feedback that you can give the participant, we will welcome this. Over to you, Dr. Admire.
Thank you. Thank you so much, and thank you for the question. I think it's a good initiative to be looking at central line associated bloodstream infection. My own experience, I've been working at a district hospital where we actually didn't have any central lines so we didn't develop that kind of tool, but I could check in my networks to see if there's any, and I'll be happy to share that one. Thank you.
Thank you very much. We have a question to you, Professor Ogunshola. It's related to ICAN. I'm talking about scholarships on IPC courses, and the list of curriculum may be provided by ICAN. If Professor Ogunshola or Anna would like to take that question, the floor is yours to unmute.
Sorry. Okay, sorry. Concerning scholarships, we're trying to get scholarships and bursaries for some of our courses. But I do know that we've also done we have ways that we can reduce the impact of those courses. And Anna is our go-to person for when we want to do those kind of iterations. But the courses cost because they're very, when you come in to do the hands-on, they're very resource intensive. So we're really trying to see if we can get funding to support some of our students, but it's a bit tough. But Anna can give you a little more, especially around the basic course, because I know we've come up with some strategies to minimize costs, but it can't go away.
Thank you very much. Anna?
Yes, thank you. Yes, what Prophet says, we're trying to do, and we look at the amount of students coming in and how we can reduce the cost, and especially now that we're trying to do it online as well to save them the cost of flying and extra accommodation. And then also depending on what exactly is their needs. So the best would be if they can get in contact with me, we can look at what is their requirements, and we can work with our partners. And I know that Africa CDC is also busy with some trainings in country, and then also with step down trainings. So we all work together and we can see what is a need, and we can take it from there. Thank you.
Thank you very much. So participants, keep an eye on both of our websites as well as all of the technical partners here. There will be training opportunities and to scale up the competencies and skills across the continent. We will keep you updated through our various platforms. So I think finally we'll take one last question, and I will pose this question to both of my speakers. It's really around, at least in the context of IPC, how can we transfer the experience learning from COVID into academic recognition? So maybe to point this question better is, from our experience in trainings provided around IPC for COVID-19, how can we start to advocate for stronger academic recognition, either through pre-service training or in-service trainings? We'll start off with you, Prof, then I'll go to Dr. Admire, then wrap up this session.
Thank you very much. Trying to put this into for academic recognition. As we said, some countries have started, and we're advocating for there's going to be a lot of advocacy, and it has started a long time ago. And so it's advocacy, and showing, and I think we've been helped by the epidemics, and all the strong partners, Africa CDC, WHO, and CDC, everybody has come, we're all looking at it that we really need to bring this into pre-service so that people don't encounter IPC at the very beginning. And one of the things we're also doing in ICAN is that we help countries to set up IPC societies. And part of the function of these societies is advocacy. How do we get our governments to agree with us, our ministries of health, ministries of education, that this should be in this pre-service training of healthcare professionals? It's a slow process, but I think we're getting there. And there are some already, yes. Thank you.
Thank you very much. Dr. Admire, would you like to make any contributions?
Sorry, I missed the first bit of the question. I don't know if you can come again.
Sure. So the question is really around how can we leverage on our COVID-19 experience with IPC trainings to maybe formalize IPC education a bit better, or transfer some of the best practices from the COVID-19 experience into improving IPC education across the continent. Over to you.
All right, thank you so much. Yes, like highlighted in my presentation, COVID-19 was really it really set the pace for that kind of transfer, and even for advocating for IPC training. I think we should also be looking at not just COVID-19, but any other emerging outbreaks. I think already I've actually seen the leveraging of experiences from COVID-19 in my locality. For instance, we've had a training in schools, training of school health coordinators, and you find that in our province we have a district where some school health coordinators and school authorities are actually trained in IPC. We actually have had also a lot of other trainings. These are probably just 3-day to 5-day trainings, but I must admit that we haven't gone to having more of the trainer trainings, and this is something that I probably envisage to see in the coming future. Thank you.
Thank you very much to all the panelists as well as the speakers for today. Anna, I'm going to hand over to you now to wrap us up for today.
Thank you very much, Dr. Wanda, and thank you very much again to the panelists. I see we've got a big amount of different partners that joined us. Thank you very much. Thank you for our speakers, Prof. Shade and Dr. Admire. Thank you for all the participants that joined us. Please remember about the French session that's happening tomorrow at 2 o'clock East African time, and I've posted the link on the chat as well. And then we will all hope to see you next week when we continue, and all the slides and the recordings will be shared. So thank you very much to everybody, and have a good afternoon. Goodbye.